Welcome to the second lecture in hemostasis and its related disorders. So in this lecture we have two topics, thrombosis and embolism. Let's start with thrombosis. Thrombosis is a pathological phenomena. Remember, it's pathologic phenomena which is comprised of formation of blood clots, which is thrombus or a thrombi in the vessels. So one important thing to differentiate here is physiological thrombus formation from a postmortem clot. So the physiological thrombus, or the thrombus that is formed in the living state, is characterized by presence of two things. First is the lines of Zahn. Lines of Zahn are the alternating lines seen on microscopy. They are alternating RBCs, then platelet fibrin lines. So there will be RBCs, then platelet fibrin line, then RBC line, then platelet fibrin line, and so on and so forth. And there will be adhesion to vessel wall. So these two are characteristics of the thrombus, which is formed in a living state, versus a postmortem clot where there will be no lines of Zahn and there will be no adhesion to vessel wall. Why does postmortem clot form? Because in postmortem state there is stasis of blood, and we know wherever there is stasis of blood there is tendency to form a thrombus and a clot. So now let's see the pathogenesis. Pathogenesis consists of primarily workhouse triad. So workhouse triad comprises of first blood stasis, second endothelial damage, and third hypercoagulable state. So let's do blood stasis first, then we will talk about endothelial damage and endothelial functions before that, and finally the hypercoagulable state. So blood stasis occurs first in immobilization. For instance, after long flights, if a subject is sitting continuously in a chair for 14-16 hours, and there's a tendency for DVT in the legs. After surgery, if there is prolonged immobilization, there is again risk of DVTs, deep venous thrombosis. Then second is cardiac wall dysfunction. Cardiac wall dysfunction can be seen in any pathology of cardiac wall, for instance myocardial infarction, hypertrophic cardiomyopathy, cardiac aneurysm, and so on. So there can be multiple causes in cardiac wall dysfunction, but the main one is myocardial infarction. Also, we can include Takotsubo cardiomyopathy, which is another heart failure disease that can cause cardiac wall dysfunction and hence blood stasis. So the third one, an important one, is aneurysm of a vessel wall, and we know that aneurysm is the dilatation of a vessel wall. So if there is a vessel wall and if it dilates at one stage or a one point, there will be stasis or turbulent flow of blood, and blood can also be static at that aneurysm, and whenever there is stasis, there will be formation, there will be tendency to form thrombus or clot. So these are the three things we need to know in blood stasis. Now we move on to the second one, which is endothelial damage. But before the pathologies, let's see what endothelial cells play a role in preventing the formation of thrombus in a physiological state. So these are the anticoagulant roles of endothelial cells. First, the endothelial cell covers the collagen underneath so that von Willebrand factor cannot bind. If von Willebrand factor does not bind, there will be no platelet adhesion, aggregation, and the coagulation cascade, and so on. Second, it secretes heparin-like molecules. We know heparin binds to the antithrombin 3 molecule, which prevents the coagulation cascade. So the heparin-like molecule secretion is another protective factor of endothelial cell. Then endothelial cells secrete thrombomodulin. As the name suggests here, thrombomodulin, the thrombus has been thrombin, or the molecule thrombin has been modified, and the modified version is now redirected to redirect thrombin to activate protein C and S, which are anticoagulatory proteins. So recall that we learned in vitamin K deficiency we had deficiency of protein C and S as well. Um, in addition to activating factors 2, 7, 9, 10, vitamin K also activates protein C and S. So that is just a link to remind you. But here the thrombin is redirected. The thrombomodulin chemical redirects thrombin to activate protein C and S, which are anticoagulatory, and prevents the coagulation cascade from beginning. Fourth is secretion of TPA. TPA is tissue plasminogen activator. We saw it in fibrinolysis. Let's take a step back and see fibrinolysis. So fibrinolysis is here. So plasminogen is activated to plasmin. Plasminogen is a protein molecule synthesized by liver, and TPA released by endothelial cell converts it into plasmin, which is the active form, and it destroys fibrin and fibrinogen, destroys coagulation factors, and blocks platelet aggregation. Therefore, it prevents formation of primary and secondary hemostatic plugs altogether. So let's go back now. Okay, secretes TPA. The fourth function is secretion of tissue plasminogen activator, and final is secretion of prostacyclin, which is PGI2, and nitric oxide. Both are vasodilators, as we saw in the coagulation and the formation of primary hemostatic plug. There was first step was vasoconstriction in order to stop the blood flow, and in order to form a platelet plug, or in order to form a thrombus there, we needed to stop the blood flow momentarily so that platelets can adhere to the von Willebrand factor and thus form the thrombus. So the prostacyclin and nitric oxide are a protective molecules that are secreted by the endothelial cells as well. So these five are most important, and you need to remember all five of these. These are particularly high yield anticoagulant roles of endothelial cells. Now, with this knowledge, let's go to the disorders of endothelial damage. So the second factor in the triad is endothelial damage. Endothelial damage can be due to atherosclerosis. Atherosclerosis we will further see in embolism. But atherosclerotic plaque formation cuts the blood supply to the endothelial cell below, and endothelial cell below, which is not getting nourishment now, will get damaged. Second is vasculitis, the same thing. Now here the pathology is in the vessel wall itself. The vessel wall is being attacked by immune system or some other factor. So vessel wall pathology will lead to lack of nutrition and inflammation against the endothelium, which will ultimately cause endothelial cell damage. Third and most important is the increased levels of homocysteine. Now homocysteine is a metabolite in the metabolism pathway. So we know that homocysteine is converted to methionine by homocysteine methionine transferase enzyme, which requires vitamin B12 and folate. So vitamin B12 folate deficiency can lead to increased levels of homocysteine, and therefore it will accumulate. Now the reason homocysteine is high levels of homocysteine are particularly bad for our circulation is because homocysteine has an SH bone at the terminal. So the SH terminus allows homocysteine molecule to bind with another homocysteine molecule, and so there is altogether a chain formation of homocysteine molecules, or polymers are formed, which can cause a blockade of blood flow and can result in stasis. Another enzyme deficiency is cystathione beta synthase deficiency. Now this is one step uphill from the homocysteine methionine transferase enzyme. The homocysteine can also be converted to cystathione, where this cystathione beta synthase enzyme. If this enzyme is deficient, we'll have increased levels of homocysteine. Homocysteine will accumulate, form polymers, and therefore will cause blockade of blood flow. This ties with biochemistry. Be sure to look at and remember this thing when you're studying biochemistry, that increased levels of homocysteine can cause endothelial damage, ultimately can lead to thrombosis. And this cystathine beta synthase deficiency is also called homocystinuria, and there is a whole cascade of symptoms, but that is not what we are studying here. So we'll study it in biochemistry. Let's move on to the third one, the hypercoagulable state. So as the name suggests itself, that it is a hypercoagulable state, that it is not physiological, because normally wherever coagulation is needed, the body does it. But if it is hyperactive, then it's a pathology, and if it's a pathology, it's a problem for us. So the first disorder is protein C or S deficiency. And remember, we talked in the previous lecture where we specifically mentioned the autosomal dominant or X-linked disorders. So this one is another one you need to remember, and this is particularly high yield. It is an autosomal dominant disorder, protein C or S deficiency. Now, why does this cause hypercoagulable state? Protein C and S, remember, were activated by vitamin K, and these are molecules which which bind to factor 5, and they cleave factor 5, making it non-usable, making it inactive. Therefore, coagulation cascade cannot go on. That's why they have anticoagulatory function. So if these are deficient, there will be no breakdown of factor 5, and coagulation will keep on moving further and further, leading to multiple thrombi formation and the hypercoagulable state. Next one is factor 5 lead-in mutation. Factor 5 lead-in mutation is very common. Normally, protein C and S deactivate factors 5 and 8. Again, this ties up with the first disorder. Protein C in factor 5 lead-in mutation, the factor 5 here the mutated factor 5, sorry, will have no cleavage site for protein C and S. That is why protein C and S, if they are present in normal quantity, even then they cannot deactivate factor 5. So factor 5 is sort of acting autonomously and continues to act. So there is increased tendency for coagulation. Third one is a specific mutation. It's a point mutation on prothrombin 2210A mutation. So this is a point mutation in the prothrombin gene, which leads to increased expression of prothrombin gene, and so therefore we have an increased activity of prothrombin. More prothrombin will be there in the circulation, more prothrombin will be converted to thrombin, its active state, and therefore the coagulation will be increased. The fourth one is antithrombin 3 deficiency. Now, before starting anything, we can already recall what is antithrombin 3 and what is its role in coagulation. So antithrombin 3 is the binding site for heparin. We already know that. Heparin binds to antithrombin 3 and prevents coagulation. So if antithrombin 3 is deficient, so heparin cannot function normally. But what happens is, in this disorder, if we check the laboratory findings, we see the PDT stays normal. This is because when high doses or pharmacological doses of heparin are given, they bind to a very small amount of antithrombin 3 that is left in the circulation, and that causes PTT to stay normal. But remember, we have to give high doses of heparin in order for the anticoagulation function to take place. Fifth is OCPs. OCPs are the culprit here is estrogen. Estrogen is a procoagulant molecule. So whenever we are giving enzyme hormones from the outside, we are increasing the estrogen active effects on the body, and one of the effects is procoagulant effect. So there will be increased coagulation. So therefore this entire thing concludes our thrombosis. Remember, we started with the definition, then we differentiated thrombus from the postmortem clot with lines of Zahn and adhesion to the vessel wall. This is very important, you need to remember that. And then in the pathogenesis, we saw Virchow stride, again very high yield, you need to remember that. Then we saw all the deficiencies and all the pathologies associated with all the three. And now finally we come to embolism. Embolism is again a phenomenon where there is formation of intravascular mass that travels downstream and occludes a vessel, causing ischemia or infarction. So this is any intravascular mass that is present in a vessel and it's downstream from its origin point. Most commonly the origin point is a thrombus, as we saw previously. When the thrombus moves downhill, it can occlude a smaller vessel, thus causing ischemia or infarction of the organ the vessel is supplying. Embolism is of various types. The first and the most common is thromboembolus. As the name suggests, thromboembolus, this is the thrombus was the origin. The thrombus breaks apart and dislodges and lodges into a smaller vessel, and that is what is written here, arises from a thrombus that dislodges. And the most important example is deep venous thrombosis in the leg veins. So the DVT, the thrombus from the deep veins of the leg migrates and occludes a small vessel, and generally, or more commonly I should say, it is the pulmonary vasculature. Now we have atherosclerotic embolus. As the name suggests, we have atherosclerosis, and the embolus is arising from the atherosclerotic plaque. The atherosclerotic plaque is whenever it's unstable, it ruptures, and whenever it ruptures, it moves downstream along with the blood, and it has tendency to block the smaller vessel. When it does blocks a smaller vessel, it the platelets sort of come together and stabilize it again and form a full-fledged thrombus. And one important thing you need to have in mind is presence of cholesterol clefts. So there will be, if you see under light microscopy, there will be presence of cholesterol clefts in the atherosclerotic embolus. That is how you can differentiate it from the others. A third one is fat embolus. Fat embolus is associated very commonly with bone fractures. If there is trauma, road traffic accidents, or any bone fracture, then as we know, the marrow contains fat tissue. So the fat tissue can embolize and cause and lodge into smaller vessels, and most commonly this lodges in the pulmonary vasculature. Therefore, the primary symptom of fat embolus is a dyspnea, and also the superficial manifestation we see is the petechiae over chest wall. Fourth one is gas embolus. As the name suggests, here the gas molecules or the gas bubbles are the culprit, and they cause a blockade of the vessel wall of the vessel. The most common symptom here, most common syndrome or the illness here is the decompression sickness. It is experienced by divers, and the idea here is that when divers go downstream, they experience increase in pressure as they descend down further. But when they're trying to ascend back up, if the ascent rate is very high, the nitrogen, which was previously under enormous pressure, now becomes now the pressure is increasing pressure is decreasing rapidly, and the nitrogen now the dissolved nitrogen from the plasma now forms bubbles in the plasma, and those bubbles can dislodge into minute vessels or capillaries and block blood supply to certain parts, the most common being the muscles and the lungs. So in the muscle, the person experiences a muscle pain, which is called the bends, the first primary symptom that is experienced in decompression sickness. The second one is the chokes. which is the respiratory symptoms, primarily dyspnea, which is due to the bubbles of gas or nitrogen, I should say, dislodging and blocking the pulmonary vasculature. Now, the chronic form of decompression sickness is called Caisson's disease, and the Caisson's disease will be characterized by multifocal ischemic necrosis, and it is very simple to understand. So you can think of it as if a diver is doing this multiple times, and experiencing mild symptoms, the bends, the chokes, in mild forms again and again and again. So if this keeps on happening, the muscle and the respiratory systems will be will get affected each time, and ultimately this will set into multifocal ischemic necrosis. Also, in laparoscopic surgery, we generally insufflate the patient's abdomen with CO2 in order to visualize and have a working space for the cameras, for the instruments and all. So that CO2, when is removed from the patient's body, can also be left behind, particularly beneath the diaphragm, which causes shoulder pains, and also this CO2 can form emboli, which can dislodge into the circulation and therefore block the vessels. Final is amniotic fluid embolus, and this is really a dreaded complication, and it is often a cause of mortality in obstetrics and gynecology. If there is any, generally it is avoided, but sometimes it does happen, and when it happens, the ultimate result is death. So it's a dangerous one. Occurs during labor or delivery. Amniotic fluid is thrombogenic because it contains tissue thrombotic factors, which you can recall we discussed in the coagulation cascade pathway, the extrinsic pathway of coagulation cascade, which is activated by tissue thromboplastin. So it has thrombogenic factors which can cause thrombus, and the amniotic fluid is the culprit. When amniotic fluid is leaked during labor or delivery and mixes with the blood of the maternal circulation, that can cause widespread thrombosis and a DIC-like presentation. Remember, we also discussed disseminated intravascular coagulation, and we said obstetric causes are the most important. So this ties with this here. The presentation will be dyspnea. There will be neurologic symptoms, and a classic presentation of DIC. Can also cause death. And the particular thing we'll find on microscopy will be squamous cells and keratin debris, which is derived from the fetal skin. We know the fetus is suspended in the amniotic fluid, and the cells keep on shedding and sloughing, and they mix with amniotic fluid. So when this amniotic fluid mixes with the maternal circulation, we can see squamous cells and keratin debris from these sides in the embolus. So that concludes thrombosis and embolism, and concludes the chapter hemostasis and related disorders. Please remember, if you need the notes, or if you need any other information, or you have any doubts, please leave comments in the comment section down below. Thank you for watching. This was a short lecture, and in the next lecture we'll start with the RBC and its disorders. So stay tuned, subscribe, and click the like button if you like the video. Thank you.